Hello, everyone. I'm Dr. Kuku, and today we will discuss on diabetes-related end-stage kidney dysfunction, delaying progression with the right dietary intervention. Renal dysfunction starts at the pre-diabetes stage with the development of glomerular hyperinfiltration and precursor of albuminuria. The effect of the hyperglycemia on kidney start early in the disease continuum. Up to 30% of the patient with diabetes present with some degree of renal impairment at the diagnosis. So pre-diabetes stage provide a window of opportunity to initiate early preventive strategies. Chronic hyperglycemia causes glucotoxicity, but further induce many pathophysiologic pathways such as oxidative stress, inflammation, that are involved in diabetic nephropathy and chronic kidney disease. So chronic kidney disease increases cardiovascular risk, challenge glycemic control, increase hypoglycemic risk, and overall, it decreases health-related quality of the life. So the question is, can we prevent or delay the CKD development and progression in patients with type 2 DM, and how? So the answer is yes. We can prevent or delay CKD development and progression in patients with type 2 DM. So we need annual screening of the urinary albumin with spot urinary albumin to creatinine ratio and estimated glomerular filtration rate, EGFR. We need early diagnosis. We need intensive glycemic control. We need intensive blood pressure control, and by timely refer to nephrologist. So when GFI less than 30 ml per minute, we need to refer to the nephrologist. For glycemic control, the KDIGO guideline recommended an individualized HbA1c target ranging from less than 6.5% to less than 8 in patients with diabetes and CKD not treated with the dialysis. The figures show the further guiding individual HbA1c target, which include severity of the CKD and comorbidity. So we need a comprehensive approach to manage patients with the diabetes and CKD. So generally, there are 4 pillars for managing diabetes and CKD, 4 pillars of the treatment. Number 1 pillar is SGLT2 inhibitor, and number 2 pillar is renal angiotensin system blockers. They are used as a first-line treatment. Another third pillar is the finerenone. This is a newer non-steroidal selected mineralocorticoid receptor antagonist. It has reduced the risk of CKD progression and cardiovascular event in patients with type 2 diabetes and CKD. And fourth pillar is GLP-1 agonist, which we cannot control the diabetes with the SGLT2 inhibitors. So apart from the pharmacological intervention, lifestyle intervention and self-management form the basis of the holistic treatment plan. Dietary adaptation must be tailored to individual needs and CKD severity. Macronutrients in our diet can potentially influence renal health. Protein, high protein intake can cause metabolic acidosis in patients with kidney dysfunction. So protein intake of 0.8 gram per kilogram body weight is recommended in patients with diabetes and CKD not treated with the dialysis. Avoidance of high protein intake of more than 1.3 gram per kilogram per day is recommended. However, the protein quantity must be adequate to prevent protein energy wasting and malnutrition. Growing evidence suggests that the source of protein must be more important than quantity of the protein consumed. Increasing the proportion of plant-based protein in diet can improve the renal outcome and reduce the cardiovascular risk. Sodium, KDIGO guidelines recommend sodium intake of less than 2 grams per day or less than 5 grams of the sodium chloride per day. It reduces the blood pressure and improves NCV outcomes. The dietary fiber, high fiber to protein ratio, lowers the concentration of uremic toxins. Fiber supplementation decreases cyanosuria and the creatinine in patients with the stage 3 to 5 CKD, not on the dialysis. Another diet is a low phosphate diet. You need to avoid the milk and the dietary products which are very high in the phosphate. So healthy dietary pattern like the Mediterranean and DASH diet reportedly slow the kidney function decline with favorable effect on cardiovascular mortality and morbidity in patients with CKD, not on the dialysis. Plant-based diet can mitigate metabolic acidosis and slow the kidney disease progression. Diet must be individualized and not to be restricted as it may lead to poor intake and limited adherence. Macronutrient distribution in diabetes specific nutrition formula DSNF closely resemble Mediterranean and dietary approach to stop hypertension diet. The SNF have low glycemic index and complement dietary recommendation for patients with type 2 TM and can be beneficial in patients with CKD. A DSNF having a protein and salt composition closest to that of the guideline recommendation may be considered for patients with CKD. So I would like to sum up by saying that early intervention at the pre-diabetes stage can prevent or delay the disease progression, as dietary priorities strongly influence CKD incidence and progression. Medical nutrition therapy must be recommended to all patients with CKD, not just as an ancillary lifestyle intervention, but as a core component of holistic management in patients with diabetes and CKD. So these are the key my takeaways. Renal dysfunction begins in the pre-diabetes stage. Intensive glycemic control can delay the onset and progression of CKD in patients with type 2 diabetes. Lifestyle intervention form the foundation in the management of type 2 DM and CKD. Diet rich in the plant-based protein, low in sodium, and high in fiber must be recommended. Protein intake of 0.8 gram per kilogram body weight is recommended in patients with diabetes and CKD, not treated with the dialysis. Medical nutrition therapy, including DSNF, can be beneficial of patients with type 2 diabetes and CKD. Thank you very much for kind attention.